Hey folks, Scott Weingart here, and this is an EMCrit We. A while back, I debated my good buddy Simon Carley, and I took the side of that debate saying that EM is a failed paradigm. Now, since then, I think most people have started to agree with my stance on that debate, in which I really argued that emergency medicine just doesn't work as a concept, at least the way it's practiced in the United States, and I think Canada as well. And, Simon was beautiful rhetorically. Behind the scenes, I think he pretty much agreed with my stance. But I got a lot of pushback from that topic when I had first put out the debate. Now, all of the pushback that I had seen, completely misguided. Everyone who pushed back is like, EM docs are great. And I'm like, that was the first fracking line of my stance, is that EM docs are great. Emergency medicine is the failed paradigm. EM docs are friggin' amazing. And if they were given a better milieu, they'd perform even better than they do. And because they're so friggin' good, they've managed to hold things together with baling wire and Band-Aids, even though the profession is completely broken. But of course, because people don't hear actual facts, they just hear emotions, all the pushback is, you said emergency physicians suck, when what I was saying is emergency physicians are great and EM sucks. Well, I guess it's right up my alley then when an article was just published, an editorial in the Canadian Journal of Emergency Medicine by two of the three guests we have here today. We have two of the three authors of that editorial. We have Paul Atikinson and Grant Innes today to talk about their paper, Saving Emergency Medicine is Less More. The last author, Ken McGeorge, couldn't join us on that day. And while I looked at this as a somewhat pessimistic article, Paul and Grant have a little bit more optimism, and we'll see if that optimism is founded. But it certainly was a good conversation. I'm going to let the whole thing run for free, so don't worry about being cut off midway through. And I'm super curious to hear what you think in the comments section for this episode. Let's jump right into it. Why don't you first, both of you, introduce yourselves and tell us what you do, and then we'll go from there.
It's nice to be here, Scott. I'm Paul Atkinson. I'm a professor of emergency medicine at Dalhousie University here in Eastern Canada. My clinical practice is with Horizon Health Network in St. John, New Brunswick. A little bit of an accent, come from Northern Ireland originally, but settled in Canada for the last few years.
All right.
Grant Innes. I'm a longtime emergency physician in Vancouver and Calgary mostly, and I'm still affiliated with the University of Calgary. I do about half-time health services research and half-time clinical work.
All right. And the reason I have both of you gentlemen on is you put an article in the Canadian Journal of Emergency Medicine that was not particularly optimistic. Maybe one of you two could jump in and tell me what the basis of that article was.
I'll just acknowledge to begin with, that there was ourselves plus another colleague, Ken McGeorge here, who's a health economist. But I would actually push back a little bit, Scott, and say that our article is optimistic. It's optimistic for the practice of emergency medicine. And we feel that it gives a pathway towards trying to fix some of the problems that we have, overcome some of the barriers that we're facing. And the gist of it, although the title, Saving Emergency Medicine is Less More, is potentially a call for help. It could be read that way, or that we're being faced with too much work. And really, I think Grant and I have been back and forth in this quite a lot. And really, he has helped frame this into something that's more of a solution-based approach than just focusing on the problem. And at the core of it is this idea that emergency medicine is valuable. What we do is valuable. We must protect it. We must even potentially extend it and develop it and take on new skills, our airway skills, our ultrasound skills, use of new drugs, use of new diagnostic procedures. But to do that, the ED, the emergency department, possibly has to do less. And that less is perhaps it can't just be the catch-all for everyone else's problems anymore if we're to do our core job as emergency physicians. So that's the premise, but Grant may want to expand on that a little more, perhaps.
I guess I'm chronically annoyed about this, being a previous department head as you are now. There's this thing, we're just chronically failing. We still have these lineups out front and people on ambulance stretchers, and the lineups are getting longer and the waits are getting longer. And there's all these solutions for emergency departments. Like they say, why don't you put in some EMS offload stretchers? Why don't you work in the waiting rooms? Why don't you set up intake areas? Why don't you make your emerge better? And people need to understand that most of the problem actually isn't in the emerge. It's out there in the system. And the problem is that patients can't get looked after. They can't get the care they need anywhere except the emergency department. Part of this is a cry for help to say, we're doing the best we can, but there's a bunch of admitted patients, mostly mental health patients, chronic disease management, surgical patients, frail elderly people, and they need better care from someone else than what we can give them.
I guess the reason I interpret your article through my lens as pessimistic is I don't feel the solutions that you two offered are going to happen. I think they were absolutely dead on. I think they were absolutely the way to go forward if we had our druthers, and I just don't see them being at all realistic. And I'll push back on a couple of the reasons why. And one of them is patient-centered care. The patients are telling us in the United States and in your neck of the woods that they want our model. They like our model. They like being able to access care when they're not working and not have to take off time from their jobs. They're very happy to not have to wait for appointments for weeks or months on end. So when they're speaking with their actions, should we not adapt to that rather than trying to make a system that's been proven not to workable?
I think we have to adapt to that. We have to provide the care that they need, but maybe it isn't necessarily in the emergency department. Maybe those primary care appointments shouldn't be 2 weeks. Maybe there has to be next day primary care access. There is in probably most parts of Europe. Maybe a specialist appointment doesn't have to take 6 months for a CT scan. And if you reduce the resistance down one pathway, then hopefully patients start moving a little bit towards that pathway.
Yeah, and I would follow up with Grant saying, I think when I came up with this idea to write again about this, and to be fair, Grant and I put out a similar article a year ago on accountability frameworks, which I think, and Grant has actually done a lot of work in this previously. I was at this conceptual fork in the roads where I was looking ahead and saying, I mean, like you've proposed here, Scott, do we take this all on? Do we expand? Do we become the superstore of healthcare? I don't want to use any branding there, but do we just take it all on? And there is an argument for that. But if you're going to do that, then you have to invest in that. You have to have the right skill set. And I don't know if current emergency medicine training really is what patients need. Sure, it's convenient. I get that. And of course, it's good care. It's great care. But is it the thorough long-term care that actually has been shown to be more cost-effective for patients? So those models, I think, need to be explored. You're right. There's definitely more than one option here. But I think what we're all agreeing on is that patients do want more convenient care. They want it when and where they see the need. But does that mean that is then the responsibility of emergency medicine? I don't think it does. But the controversial part to this argument is, as Grant alluded to, like electricity, like water, patients tend to flow where there's least resistance. Perhaps I certainly think in our area, we're starting to see that patients are looking for alternatives. And I think COVID and the pandemic has really opened up the eyes of other providers to those alternatives. I've certainly seen new models of primary care being proposed here in Eastern Canada. Certainly the use of telemedicine has picked up. Now, is that going to address people's emergency problems? No. And I think this is the core part of our argument. We're not actually talking about trying to offload emergency medicine. We're saying patients have other healthcare needs and they've turned to emergency medicine when in fact they should be looking elsewhere. So hopefully others will respond to that.
Let's dichotomize the issue you just raised, Paul, because I think you're absolutely right. But I think it becomes confusing when it's blended two separate issues into one. You didn't do that. I'm saying the field in general does it because there's the patient who comes to us knowing there's no emergency in their hearts, but they want care. And that's a group that I think the things you've just mentioned. And then there's another group of patients who come with things we deem non-emergent, but they truly feel, I'm worried, something's going on. Now, both of those are issues because both of them aren't true emergencies. But in the former category, solutions like telehealth may help, and maybe teletriage could address the second to some extent. But there's always going to be a group of patients that come to us and they just need to be discerned as sick, not sick. And then the question, and the reason I raise this, is what to do with those patients when we quickly discern they're not sick. And there is a debate piece that, Paul, you moderated, I believe, in the CGEM on this very issue. I believe it was Brian Rowe, and I forget who took the pro side on non-emergent patients not being treated. But what do you feel about that at this stage of the game? I think at a higher level of frustration you might have been when that piece was.
Yeah, and that was the ED diversion piece, right? So we had a team from Quebec who were arguing the opposite because in Quebec they actually have a formalized ED diversion program. I think that's a really key part to this, but not actually, again, what I think we were focusing on, because what you're talking about there are patients who present themselves to us. And I do think we have a responsibility to really take their concerns seriously, whether that is a triage approach, reassurance, and pointing them back to an appropriate healthcare provider. I think that's not an unreasonable approach in emergency medicine, but it needs to be done safely and thoroughly, or whether we actually are resourced to take on those issues and investigate them further. Sure, we can debate that. But what we're actually saying is there's actually a third group, and that is the people who are directed to us by the system. And so that's and they are not low resource patients. They are high resource patients. They are the people who are perhaps in a nursing home where there is someone covering, but unfortunately it's the evening or weekend and that cover doesn't extend to actually seeing them, whether it's a post-operative patient, whether it's we're not pointing fingers at our colleagues. What we're saying is the system doesn't support them with resources to manage patients in the community. They end up coming to us. So investing in those systems could be useful. So I'm not actually a fan of ED diversion. I really am not. I think if someone comes to us, we have a duty of care to make sure it is not a true emergency. But Grant, I don't know. Yeah.
Yeah, no, I don't want to divert anything that's acute because I think that's what emergency departments were for. I think that's what we're good at. I think that unfortunately, there's so many doors to other programs out there that are closed that now we're getting hugely increasing numbers of chronic and complex. And first of all, I'm not very good at that. And second of all, as you suggest, Paul, those are very complex. And they eat a lot of emergency resources. And of course, the critical group of patients that I guess have been diverted to an emergency department that we haven't talked about yet are the admitted patients. So here's a group of patients who are supposed to be getting appropriate inpatient care. And the inpatient services say, oh, sorry, we're full. You're just going to have to deal with it. And so the people that I want to divert for their own sake so they get better care are the chronic, the complex, and the admitted patients. And I hope we can manage acute patients.
Let me separate out what you just said, Grant, into two, because I want to talk about those admitted patients. That's a huge issue. Let's put a pin in that just for a moment. Let's deal with these complex nursing home patients first, and then let's come back to those admitted ones, because I think the admitted patient issue is enormous and perhaps the biggest problem in emergency medicine right now. But let's push back a little on this nursing home complex patient transfer. Okay, so we now get what we should have, 24-hour coverage with a doc at that nursing home. They don't have resources for these the more complex they are, the more difficult it's going to be for that poor soul at that nursing home to manage it. They can't get a CT scan. They can't get labs back with any alacrity. Now, there's certainly, and I don't know if this is pejorative to anyone, I can't imagine it is, but there's certainly nursing home dumps that we all experience in emergency medicine where it's just like ridiculous why they sent the patient. Peg tube fell out being one classic example. That's an enormous burden of transfer and whatever for someone to stick a Foley in there. Granted, I give you that. But the ones I don't want from the nursing home, the complex ones, are exactly the ones that deep down in my soul, I empathize with them sending them to me because they have no capability of discerning whether this is a sick or not sick patient for the most part. What do you have to say about that?
I think that situation, that's a very cognitive situation. And in one of the facilities, in the transferring facility, you have physicians that know the patient. You have physicians and staff that have seen the patient over time. You have people who have an understanding of chronic care, long-term care. Now they can't manage the patient, and they're sending the patient to me, who I've never met the patient. I don't know what their baseline is. I don't know what their goals of care are. I don't know what their target is. I don't know what they're supposed to be like. And I'm not a long-term care physician. I don't do that kind of work. And they're saying, well, why don't you make the decision on this patient? It's rather inappropriate. Now, if I'm merely a conduit to a CT scan, I think that's fine. But having me make the decision about putting this patient in hospital, that's a mistake. And my father is older. He's 90. He was just in the hospital, sadly, because of COVID. But after several days in the hospital, it began to strike me with increasing clarity, something I've known for a long time, which is you put an older patient in an acute care hospital bed and have them looking at the ceiling, they will rapidly decondition and cognitively decline to the point that they will not recover and be functional again.
Paul, what do you have to say?
Yeah, I think a lot of this comes down to stories and experiences for patients, not so much just what is easy for the healthcare system. I think we have to go right back to why we went into this game. Like, I really do. I believe, and another paper, not to keep self-citing here, but I really do feel this, that I put a paper out with 3 principles. The first is you got to have the resources to do the job. The second is you got to have the training, right? And the third is you got to have compassion. And if you have those 3 components, I believe you can achieve a standard of care no matter what system you're in. And so to your point about these patients, what I have seen and what really I take home with me, and I reflect on it a lot, are elderly patients lined up on ambulance stretchers with nowhere to be placed. And so all we're asking for is an integrated system that does not point everyone at a bottleneck that's already backed up. That doesn't allow anyone to practice good medicine, whether you define that as emergency medicine, geriatric medicine. And maybe this isn't the case in every system across the world. And I'm not sure. I'm sure there are places in the States where there is a good flow. But right now, in many other systems, certainly Canada, UK, sending that nursing home patient in, you can be basically, it's a sentence of an hour or 2 in a hallway with no bathroom, with no privacy, then perhaps in a crowded environment, being pushed around. You don't know anyone there with COVID restrictions. You don't have a caregiver with you. And a lot of these patients are confused. I believe it is actually, it's cruel. And so I think we have to step back and say, what's the business model here? Can this patient, with someone who knows them, come up for what they need, which is perhaps a scan and some lab work? And can't we use modern technology for perhaps, right now, look, we're all conferencing right across North America, but we're talking as if we're in the same room. Why not utilize that technology to empower the physician at the nursing home to actually be present with the patient on their journey, make those decisions, get them back to the nursing home if they need to, or to whichever service they need. Unless, of course, it truly needs our skills. And look, you are a critical care emergency physician. I love the T-shirt you're wearing. It speaks to what we do. And so if they need me, if they need you, if they need Grant, of course we want them. But if it's just they need tests, or they need a diagnosis, and they are a physician and the resources are there. We need to join those up and really allow us to focus in on what we do best. I think that's what we're saying here.
Yeah, I hear you. And I think some good points were made. I think we get now to the issue we put a pin in, which is, look, these nursing home patients don't bother me that much. They're really not the issue, because for the most part, and Grant, I completely agree with you that a patient who doesn't need a hospital, the worst thing you could do for them in elderly age groups is put them in the hospital. But let's pretend they do. That's not the bottleneck. The bottleneck is that we can't get them upstairs. In fact, most of these patients are very rapidly disposable. So let's talk about that. Let's talk about admitted patients. Now, I'm going to put forth what I feel Australia and the UK were just absolutely incredible to me, how short-sighted the 4-hour rule was, when it seems like anyone in emergency medicine could have advised, with the simplest change in language, a dramatic solution to their problems and what I think we should adopt in the US and Canada, which is they made a 4-hour rule saying from the time you hit the emergency department, you must leave the emergency department. And it's in my readings of it and speaking to our buddies, it's a failure. It leads to bad care. It leads to a accelerated disposition attempt, or these short stay units that were created simply to get around a rule. When if the 4-hour rule was from the time the emergency doc wants the patient admitted to the hospital, they have to be out in 4 hours. It seems like it would solve all of these issues. And those two countries show that you can have governmental interventions that can be enforced. But the governmental intervention seemed absolutely ludicrous. If we had in Canada or the US a rule saying from the time you ask for admission to the hospital, they must leave the emergency department within 4 hours, would this solve the problem?
I think that's a really good suggestion. In both BC and Alberta, we were successful for a period of years introducing overcapacity flow protocols. And the way they worked was very simple. When a higher acuity patient, triage 1, 2, or 3 patient came into the emergency department, they could not be blocked in a waiting room. They had to be allowed into the emergency department. If the emergency department was full, then the most stable admitted patient went within 15 minutes to the appropriate inpatient unit. And so it forced the accountability. And of course, all the patients who were pushed were at or more than 4 hours from an admission decision. But you can have a policy, you can have a 4-hour target, but you actually have to have a strategy that operationalizes that process. Otherwise, it just doesn't work.
And Scott, if I can follow on from Grant, and at the risk of possibly offending all my previous colleagues in the UK who've stuck it out there, one of the reasons I'm in North America is because of the 4-hour target. I thought settled in a very exciting position in Cambridge University. It's a nice clinical academic mix. Who wouldn't want that? Why would you leave that and go to Canada? Because on every shift, I had a manager on my shoulder saying, you've got 15 minutes to decide if you're sending that patient home or admitting them. And I felt that it was really eroding into my clinical practice and my autonomy as a physician to make good decisions. So I agree with you that target was probably perhaps misplaced in terms of the focus. But I would also say that having no target, and if you look at the recent data now that they've relaxed that target, everything is slipping big time in the UK. So I think we do need some form of target.
The last issue I have on my list, and then I'm happy to talk about anything you two want after that, is would you say right now the emergency department is a safe place for a truly critically ill patient?
No, not all the time. And of course, we got to be careful here not to breach any patient confidentiality, but even in a department that's a tertiary hospital, it's a level 1 trauma center where I work, but it's not New York City, right? It's not downtown Toronto. It's a small city. But even there, we have patients who arrive with chest pain who sometimes code in the hall. We have patients who lose their blood pressure waiting for transfers for CT in the hallway. We have children who come in who are still in the waiting room whenever they have to suddenly be rushed in because they become cyanotic. So yes, and we all know we're all connected, right, through the emergency medicine community that we see this every day. And I would say, I mean, what I have pushed in my organization, and both Grant and I are pushing here in this article, is let's take a risk-based approach. If you have a stable diagnosed patient, they've had their treatment started, they've had their tests, and they've even been seen by a specialist, that patient has to be, by any measure, a lower risk patient than the person who's in the waiting room, than the person who hasn't come in yet. So all I'm really asking for is a risk-based approach. Let's use a quality framework to assess risk. Now, one of the ways that we've been piloting in the last month is what we call a flow center. So we in a way, while I'm calling for help and I'm hoping that the cavalry will come and things will change, we know that it won't happen very quickly. So we took this on and we committed to seeing every level 3 and above, 1s and 2s come in. So these are the urgent patients, the middle group, to see them all immediately. We bring them in, a doc goes, sees them, makes sure they're stable, can order some tests. They might have to go back to chairs, but at least they've been seen. And so for me, that lowers that risk. It doesn't solve the problem, but it lowers the risk. And so in a way, I think that's what emergency medicine is about. It's risk management and key interventions to lower risk.
And emergency departments are not just if the patient is triaged. You don't know what's wrong with a patient after they're triaged. They have leg pain, and what their diagnosis turns out to be is necrotizing fasciitis, or they have God knows what in the waiting room, and it's not adequate to say, anyone here with chest pain? Anyone here with chest pain? Okay, you get to come in. We miss too much out in the waiting room, and as Paul suggested, if you can't see those patients, it is not a safe emergency department.
What else should we speak about before we call it a day?
I'm interested in exploring a little bit, but I know it's a big debate. We have taken on skills over the past 30 years, more, probably 40 years. But I think certainly over the past 20 years in my experience, actually, I shouldn't say that. It's now 27 years. Time flies. Emergency medicine has grown in many ways. It's grown in its we've talked about in what it deals with, but it's certainly grown in skill set, maturity, it's the literature. And we're still young, but we're actually very advanced as a specialty now. Do we keep growing? Do we keep taking more on? Do we keep saying, we can do this, we can do this, we can do this? Or, as perhaps we're asking in this article, is it time to pause and say, have we grown too much? Are we trying to do too much? Is it time to think, what's the core purpose? Why do we exist? And that's not to say we don't do that. That's not to say we don't advance how we do that, but to draw a circle around, this is what we do. Where do you draw that line, Scott? Because I know you're into that debate.
Yeah, I'm going to have an unpopular opinion for many, which is, I think we have to go with what our patients want. And I think what they want is a doctor who is there 24 hours a day, who is well-versed in primary care, as well as possessing a remarkable skill at detecting subtle, serious disease, and can manage pretty much whatever presentation comes for the first 20 minutes. And I think to try to be what the name would imply, which is a resuscitative specialty beyond those 20 minutes, which is what we're being asked to do right now, and being asked to be a primary care physician and a medical detective, it's not viable. And I think the specialty will experience a schism. And those two divergent paths will break off into two separate specialties.
Yeah. I don't disagree with you. And I know you've debated this with our good friend Ken Mill, Cape this year. And the model, and we got to be open here, both Grant and I are Royal College trained emergency physicians, but so primary care comes as an add-on and we have to go learn it.
Yep. But you have a whole bevy of people who went through the family practice route in your neck of the woods.
Yeah, exactly. And so I think perhaps in Canada, you almost have that schism, not in how we practice every day, but perhaps in how we see ourselves, perhaps in how we see our job, right? Yeah.
Paul, I'll give you the final word.
Well, thank you. And thank you for really allowing us to explore these issues. Emergency medicine and emergency departments, although we are symbiotic, we're not exactly the same thing. And I think the debate has to be clarified there. And to your point of whether it's a stretch in breadth of knowledge and spectrum of disease, or whether it's a stretch in terms of how long you look after the patient for, I think we have to decide which way we stretch. We can't do both. We're stretched too far. And so that brings us back to the less is more. I really believe that. So let's decide, is it less in that we come into what our core skill set is, and we do that really well and thoroughly? Or is it less in that it's the time we're expected to manage patients for? So yes, they all still come to us, the nursing home patients, the post-op patients, we deal with it, but we're not stuck with that patient. We then move on to the next patient and they move off to the appropriate place. Whichever it is, let's decide and let's move in that direction.
Yes, I completely agree with that. That's the perfect place to stop. Fantastic.